Thank you, Hashim. And first, I'll request all the panelists to please, if any one of them is there, to have their seats on stage. Shehbaz Qureshi, Dr. Abu Bakr, Akhtar Bandisha, Iftikhar Ahmed, Atif Khan, Hamza Ghori, Samiullah and Salimullah. So I think let's start with the case Muhammad Amin from Tabba Heart Institute, left main PCI and distal RCA bifurcation stenting.
Assalamu alaikum everyone. Thank you for giving me opportunity to present my case at this forum. My name is Dr. Muhammad Amin. I am Intervention Cardiology Fellow at Tabba Heart Institute. So my case is of 70 years old gentleman. He is hypertensive. He had history of the inferior wall MI in 2014. Underwent primary PCI to the RCA. He was doing well and being regularly followed up with his primary cardiologist. 1 week back, he had severe central chest pain and he presented at the tertiary care hospital and he was labeled at non-ST elevation MI. His angiogram was done and he was advised cabbage. He refused the cabbage and he visited our outpatient department for another opinion. His EF was 45%, EKG shows subtle STT changes in the inferior leads, and the patient was currently asymptomatic and clinically stable. So this was the angiogram. Actually, these are the pictures which are taken from our the guide catheter, and the real angiogram was performed outside our hospital, so I couldn't have those images. So his proximal to mid RCA stent was patterned with mild to moderate ISR. Along with that, he had severe bifurcating lesion in the distal RCA involving the ostium of PTA and PLV. His left main was also severely diseased with proximal to mid LAD involvement. Circumflex was non-dominant and it was non-obstructive. So we advised him the coronary artery bypass grafting. The patient again refused it. So we decided for the multivessel PCI. So we decided to fix the RCA first. It has the Medina classification 111, and the provisional stenting strategy was adopted as it has PLV was of good size, but there was only ostium involvement with lesion less than 10 mm. So the provisional strategy was planned. Right radial 7 French axis JR4 guide was taken and both the PDA and PLV were wired with the workhorse wires. The PDA was dilated with 2015 balloon up to 16 atmosphere. Soon after the dilatation, there was severely compromised RPLV branch, which is unfortunately not shown over here, but it was severely compromised. So we decided for stenting. So after the POBA to the RPLV was 2015 balloon at 16 atmosphere, a dash of 3026 was deployed in distal RCA to the RPDA, and it was deployed at 12 atmosphere. The part with 3512 NC was run up to 18 atmosphere. The RPLV was rewired and again the POBA with 2015 balloon was done up to 16 atmosphere, and the dash of 3012 ATM was deployed at RCA to the RPLV at 10 atmosphere using the TAP technique. So TAP is basically a bailout strategy when the provisional stenting was adopted. So it is the most important step is the stenting and the positioning of the stent at the side branch. So the side branch, which was the RPLV, The stent was deployed in such a way that its proximal 1 to 2
Sorry, just to
struts.
interrupt, you have 5 minutes to complete your case.
Okay. So the stent was placed in such a way that 1 to 2 struts should be in the main vessels, and it was deployed at the 10 atmosphere for the full coverage of the ostium of the side branch. The KBI was done simultaneously at 10 atmosphere. Report was done with 3, 5, 12 NC up to 20 atmosphere. The proximal to mid stent, which is having the mild to moderate ISR, the FFR was done, which shows 0.86, that is negative. So it was kept as it is, and this was the final result of RCA. Moving towards the left main stenting, EBU 345 guide was taken, and left main LED was wired, and also circumflex was wired. LED was pre-dilated with 215 balloon up to 16 atmosphere. A dash of 27526 was deployed in the proximal to mid LED at 14 atmosphere. Another dash of 3526 was deployed in the left main to LED, overlapping the prior stent at 16 atmosphere. It was post-dilated with the stent balloon up to 18 atmosphere, and the left main stent was further post-dilated with 4 or 12 NC up to 20 atmosphere. The IVUS was done, which shows the well-deployed left main to LED stent, but there was slight under-deployment of the proximal to mid LED stent, which was further post-dilated with 3 to 5 NC up to 20 atmosphere, sorry. So this was the final result of the left system, left main to LED, TIMI3 flow with good results. TAP is basically a modified T stenting technique and used as a bailout strategy for side branch stenting during the provisional approach, and for PCI in the bifurcating lesion with wherever there is high probability of requiring the another stent, as in our case. So the important step is the stent placement. There should be slight protrusion of the side branch stent into the main vessel to get the full ostium coverage. It is suitable for the bifurcation angle 70 to 90 degree.
I think we can stop here for sake of shortage of time,
Okay.
and take comments from the experts, any comments from the audience, rather than theoretical discussion of TAP. Any comments about the case?
Yes, as far as the PCI of RCA to PDA is concerned, I think in order to go for the TAP stenting, first you have to do the KBI and then reassess the stenosis of the PLV. If you are committing to do it provisionally, then you have to assess it after kissing balloon inflation rather than after just stenting. I think to me this is the point. You are right that PLV was a big size vessel. Either you might have gone right from the beginning that two-stent strategy might have been applied, but if you were to go to the provisional stenting, then I think after kissing balloon inflation, you have to assess the side branch.
So the thought process over here was we should go for the, after the POBA to the RPDA, there was significant stenosis and pinch of the RPDA. So we decided to go for the stenting. You are right, we should have done the KBI, but it was giving major supply to the myocardium. So we decided to do the
I think
TAP
in
as
this
a
case, these two lesions right from the beginning are looking very severe. Usually bailout you already have a 60-70% kind of lesion in side branch, and your main lesion is there in the main mother vessel, whatever you are opting for. And your side branch has a chance either to remain patent or you can get away with ballooning. And right from the beginning, I think both branches were having almost 90-80% diseases there.
Yes,
so
but
looking
it-
like a case of elective double stenting, and both are
Yes,
sizable
but
vessels.
it was a focal disease within 3 millimeter of the side branch.
really-
That's why it could have been done provisionally, but it could be a operator-dependent decision.
And other thing I think that we saw during the case, I think there's another consideration which comes into the account as well, that you see you were considering a provisional technique. So was there any consideration given of going for a DCB to that small branch distally? That could have been one option. And then again, we already know that if we have good enough pre-dilatation and there is no residual stenosis, no collapse of more than 30%, no recoil, and there is no flow-limiting dissection. So all these things do give us the confidence, and we do have the evidence that maybe DCB is going to hold on. So that could have been one of the things. But I think considering the bifurcation, provisional was the way to go, and TAP seems to be the easiest way to go about it, especially when it's a distal vessel. However, the angle was not that favorable for a TAP, so that's my opinion.
Any other comments so that we can switch to the second case?
Okay, just have a question. There is still a debate that whether pot should be done or not, because who is there with pot? You can crush some of the stud after the TAP. So a bit debatable whether pot should really be done after tape or not. The other thing, in the provisional, still if you have done the tape, it's okay. It's still the tape doesn't mean that it is just from the first say that it is just a two-step technique. If you have just done the tape, this is a part of the provisional strategy. We are okay with that, but just still debatable whether pot should be done or not. Thank you.
Do you want to say anything about it? I think if you are
Yeah.
keeping yourself away from the carina and you have proximal adequate stent, then there won't be an issue of crushing the stents rather than. But you have to keep away from the carina, keeping yourself proximal. So I think
Sir,
let's move on to the second
excuse
case. We will find a lot of
This is Mawaz.
things for discussion in subsequent. Actually, they were started with a bailout technique. They weren't considered this case to be of elective double stenting.
जलाल माइक ले लें.
Maybe they thought it was.
हाँ 2015 से 2015 से हाई प्रेशर पे अंडर.
Okay, I think let's move on to the next case.
Thank
For
you.
that, I'll request Dr. M. Ishaq from Peshawar Institute of Cardiology.